Welcome back to another episode of Parentcast. I'm your host, Dr. Jennifer Arnold. We all have our preconceived notions about our wisdom teeth. Should they come out? When do they come out? Does everyone get them out? So I'm excited to dive into this topic today with our guest expert and learn more about those supposedly very smart teeth. As always, let's start off with a question from one of our listeners.
Hi, I'm Pam. Our dentist says my 15-year-old should start thinking about getting their wisdom teeth out, but nothing hurts and it feels early. How do I know if it's really necessary?
Parents like myself who want to make an informed decision have a lot of questions about when and if to get your wisdom teeth out. Today, we are in luck because we have our expert, Dr. Bonnie Padwa. She is our oral surgeon-in-chief here at Boston Children's Hospital, and she works closely with families, dentists, orthodontists, pediatricians to help each of us make the right decision for our kids about having our wisdom teeth removed. Thank you so much, Dr. Padwa, for being here today.
Thanks so much for having me. It's a pleasure.
I always love to ask each of our guest experts a little bit about how they got into their specialties. So how did you get into your field?
Well, I grew up in a family where both of my parents were scientists, and they were always asking me at a young age what I thought I might like to do when I grew up. And I was a candy striper in a hospital one summer, thinking that perhaps I wanted to be a physician. So I was seeing an orthodontist at the time, and it seemed like a nice specialty. And so at a very young age, I made the decision I was going to be a dentist and an orthodontist, and went through college, pre-dental, and then came to Harvard Dental School. And the first 2 years at the dental school at Harvard are also medical school. We had a course in embryology, and my dear colleague, Dr. John Mulliken, gave a lecture on facial differences that develop and the surgical procedures to correct them. And at that stage, I decided that that's what I wanted to do. So I spent the next 10 years through dental school and then medical school and residency and fellowship. So that's how I got into the field of oral and maxillofacial surgery. And as part of that field, dealing with teeth is a large part of what we do.
So you are an oral surgeon and a dentist, and so you combine both of those skills to really provide amazing care. Well, we're talking about wisdom teeth. The question I think probably our audience wants to know, like I want to know, is, really what are the wisdom teeth? Why are they so special?
Well, wisdom teeth are the third molars. They're the last teeth to form and the last teeth to develop. And as man has evolved over the centuries, we went from having a very coarse diet requiring big jaws to having more refined diet, and the jaws have slowly gotten smaller. So now you have the same number of teeth trying to line up on a smaller jaw, and now there's just not enough room for them. So they get stuck under the gum or the bone or a combination. That's what we call impacted wisdom teeth. So even though they're stuck under the bone and the gum and you can't see them, they're not symptomatic, they can certainly be causing problems silently.
Wow. And so impacted doesn't necessarily mean infected, just so that everyone knows. But because of that impaction, you can have increased risk of infection.
Yes. Particularly when they're angled forward, they can press into the back of the second molars. They can cause crowding of the teeth. They can cause melting away or resorption of the back of the second molars, and they can also pull the gum tissue away from the back of the second molars, creating a food pocket where food debris gets stuck, and then the bacteria that live in your mouth use the food debris, produce acid, which then causes cavities and bone loss on the back of the second molar.
Wow. And so when do the wisdom teeth typically come about or come up?
When you look at the bell curve of tooth development, for most people it's around the age of 18 is typically when we take them out. But we have the extremes on the spectrum. We have very precocious dental developers, and at age 15 their wisdom teeth are ready to come out. And then we occasionally see some very delayed patients who are 20s and they still don't need them out. Somewhere around 16 or so is a typical age. Wow. But it's not uncommon for the dentist and orthodontist to take a screening panoramic radiograph, which is the x-ray that goes around and gets the full jaw and all the teeth, somewhere around 15 or 16. And usually when they take that x-ray, they send you to the surgeon to have an evaluation and for us to decide if and when it would be appropriate to remove them.
Why are the wisdom teeth called Wisdom teeth, are they smarter?
No, I mean, I think that's because they're the teeth that come in when you go from adolescence to maturity, and people think that they brought wisdom with them.
I don't know if I'd call my young adolescent wise yet, but I love that. I love that. One of the things you mentioned is that some of the reasons that you need to remove them, you may not feel or see on the outside. As a parent, knowing that my son, I just got told that it's time to get his wisdom teeth out, and I haven't acted on that yet. It reminds me that you don't have to have any signs of pain or irritation. It just may be time because of the way things develop.
Yeah, it's rare at a young age to develop a problem. Usually it's something that happens later down the road, but on occasion we do see patients who've had significant resorption or decay develop on the back of the second molars, and they're completely unaware. Usually we don't see it at this age, but we know it's going to happen, and we usually recommend taking them out before it happens.
Yep.
And it's certainly a lot easier to take it out the younger you are. So we'd like to try and get the wisdom teeth out before the early 20s. The wisdom teeth are not fully developed yet. The bone is still a little more flexible, and the older you get, the denser the bone gets and the more brittle the teeth get. So from a surgical standpoint, it's a little more difficult to remove them.
Probably more painful?
Probably the recovery is a little more difficult too. So we try, if patients have impacted teeth and they look like they're likely to cause a problem, if you left them forever, we try and get them out sooner rather than later.
Yeah, just thinking about my own childhood growing up and having friends that got their wisdom teeth out. I feel like back then, they were saying, oh, my teeth hurt or something. And so then they got them out. But now we know better, right? We know, let's get in there earlier before it causes a problem is what it sounds like.
Yeah.
And so having that good conversation with your dentist and the oral surgeon is really important. And I'll just tell everybody in the audience who are listening that the reason I still have mine is only because I had 8 other teeth removed when I was a baby.
Yeah, so, again,
that's unusual.
If you think about the arc of the jaw and lining all the teeth up, if you have a small arc and normal or large teeth, you're not going to have room for them. Or if you have a large arc with small teeth, you might get them all in. Or if you have a normal size arc and you've removed a tooth, then everything slides forward a little bit. It can make some room for the wisdom teeth. So it's not that uncommon when patients have had premolars removed for orthodontic purposes for them to have potentially some room for their wisdom teeth.
To keep the wisdom teeth. Interesting. So for parents listening, hopefully this helps them to understand why their doctor may be saying it's time to get your teeth removed.
Sometimes the dentists take the x-ray and they see the wisdom teeth and they send you off to the surgeon. And we don't recommend that they come out right away in every patient. So it all depends, patient by patient case basis on if they need to come out and when. But I would say the majority do require removal.
I haven't removed my son's wisdom teeth yet, gotten them removed, but I know that it's soon. We want to get it before. Based on what you're telling me now, it becomes harder and more painful over recovery. But what I've always heard to be worried about is that impaction. So do I need to be worried about his teeth getting impacted?
I'd say it's more common to have an impacted wisdom tooth than not, only because, again, there's just not enough room for them. So they don't have room to erupt. And as I mentioned, impaction just means they're stuck under the gum and the bone. They don't have any place to go. So in about 90% of patients, the teeth would be impacted.
So when you say erupt, that sounds a little bit scary. Can you tell me what you mean by that?
When a tooth erupts, it just means it comes through the bone and then through the gum tissue. So it comes into the oral cavity. That's what eruption means.
Gotcha. So something we totally expect to happen.
Yes, exactly.
So it sounds like the care should be individualized, but it does also sound like once your doctor says, it's time, how much time do you have to wait? Again, I might be asking personally because I haven't done it yet for my son.
It's rare that it's an urgent situation. Most of the time I'm telling people this is an elective procedure. Just find some time in the next 6 to 18 months that will work in your schedule.
That's great. Okay, so I'm still good.
Yeah, you're good. And I tell parents the summer before they go to college, that's a very common time to do it. All the kids come in and have their wisdom teeth out.
Sounds like a rite of passage.
Yeah, exactly.
Okay, so I'm sure many of our listeners want to know, what does the surgery itself look like?
So it's generally a very well tolerated procedure. For most patients who are healthy, we do this in an outpatient setting in our office. We provide a conscious sedation, so we place an intravenous line and give them some medication to make them comfortable, along with local anesthesia or Novocaine to numb their mouth up. The procedure usually takes about 15 minutes. Patients are typically in the office for some prep work and post-operative instructions, and then placement of the intravenous and sedating the patient, the procedure, and then waking them up and discharging them. So it's about an hour and a half start to finish.
Great. Not very long.
No, it's not. It's not long. They have to be accompanied by a responsible adult who takes them home afterwards. We usually say plan to rest on the couch for the afternoon with ice on your face. Soft, cool diet is good. And we don't prescribe any narcotic pain medications, just utilizing Tylenol and ibuprofen.
Which is different than it used to be, right?
Very different.
You'd hear about very strong medications being given.
Absolutely. Standard would have been a prescription for 20 Percocets.
Wow.
But trying to be responsible prescribers, we did a study maybe 5 years ago where we asked our patients to keep a pain diary afterwards. And we documented that very few of them used any of these pain medications. So we decided to just not prescribe it at all. And I would say 99% of the time, we don't get a phone call. On occasion, somebody will call and we'll have to send them a prescription, but it's pretty well tolerated. We've also changed our protocol a little bit to use a long-acting numbing medicine, so they stay numb for 6 hours afterwards. We give a long-acting non-steroidal anti-inflammatory like a ibuprofen type, and a little bit of Decadron to help with swelling. And so I think the combination of those things within the first 6 hours, 6 to 12 hours, helps mitigate pain. And then we use an alternating Tylenol ibuprofen routine that our PAs and nurses review with the family before they leave.
Wow. So we've definitely, sounds like we've got a better sort of plan during the procedure to help with pain. Inflammation of itself causes pain. So if you can decrease that inflammation with the IV medications and then have a longer acting pain management locally, that makes a huge difference. Yeah. We see that in a lot of different procedures nowadays.
It's been working really well for us.
That's really great. And so kids and young adults can get back sort of into their normal routine pretty quickly?
Yeah, we usually remind patients that they'll need 4 or 5 days to recover. So, we don't ask you to sit on the couch, but I always tell patients don't plan any big events like a soccer tournament, an exam, or a paper that's due, or going to a party you want to look your best at. I probably wouldn't expect that in the first 4 or 5 days. So, take it easy, lay low, but by 5 or 6 days post-op, most patients are feeling much better.
That's great. Can you eat your regular diet? Any restrictions after surgery?
Well, we ask that they stick to a softer, cooler diet. The hot foods will increase blood flow to the area, which might result in some postoperative bleeding. So in that first 12 to 24 hours, sort of cooler, ice cream is good. And then soft, because you'll have a little swelling in the back. And if you're doing a lot of chewing, you can chew on some of the swollen tissue. So soft foods are better.
Soft foods, that does make sense. So it doesn't sound too bad.
I mean, it's not, look, nobody would sign up to do this if they didn't have to, but if it's something you have to do, I think that patients do very well afterwards.
Yeah, that makes sense. Well, what about those maybe with more complex medical histories? I think about my kids, they do have some other diagnoses that might make airway management more challenging, being in a children's hospital like we are, how do you manage those patients?
We always touch base with the providing team to obtain clearance. So if, say, for example, a patient has diabetes, we'll talk to their diabetes doctor about how to manage them. If they have a cardiac issue, we'll talk to the cardiologist. Part of that discussion will also be the best setting in which to take out the wisdom teeth, whether they're candidates for our office for sedation or whether they'd be a better candidate in the operating room either with sedation or general anesthesia. And, now the beauty with Epic, we can also see our local hospitals and look at doctors' notes and know who the providers are and be able to reach out to them directly if the providers are not at Children's. So we always obtain clearance for anybody with a medical history, and then that a clearance includes helping us plan for the procedure itself and also the best venue.
Yeah, no, that's so important because obviously safety is first, and for some kids, because of their medical complexities, it might just be better in the hospital setting to be safe. But not necessary for all kids, which is great.
We're always in the hospital setting because our office is in the hospital. But it's that's considered an outpatient like any
other ambulatory,
any surgeon's office, but specifically the operating room we have available to us.
So it's something definitely to talk about with your oral surgeon and your care team. That's great. Just for our listeners, Epic is the name for one of the electronic medical records, which as we have electronic medical records now everywhere, it makes it easy for us as clinicians to find information on our patients that is related to their care in other locations. So that's really important.
Yeah, very helpful.
In addition to the medical reasons why some kids might benefit from having their wisdom teeth taken out in the actual operating room, what about other children who may have more social, emotional needs?
So, like everywhere else at Children's, we try and provide family-centered care. So this is a discussion that we would have with the patient and their family about what the options are for the different venues and help them with us work through what the appropriate place would be for this procedure to be done, either in the operating room where we can provide a full general anesthetic or in our office setting where we do a more moderate sedation.
That's really important. And I think for hopefully all parents to make sure they're having that conversation with their surgeon about, what is the best location, what is safest, and what might be most supportive for that individual family and child. Let's talk a little bit about our program here and the oral and maxillofacial surgery program at Boston Children's. Can you tell us a little bit about the care that you provide? I imagine it's more than wisdom teeth removal.
It sure is. Wisdom teeth removal is a large part of what we do, but certainly not the only thing. So wisdom teeth removal is in the spectrum of things that are what we would call dentoalveolar surgery. So basically surgical procedures that involve the teeth and jawbone. So things like taking out baby teeth, taking out teeth for orthodontic reasons, exposing teeth that haven't erupted yet to help with orthodontic eruption of these teeth. So all of those kind of minor oral surgery procedures that involve teeth. And then in addition, we really manage cysts and tumors that occur in the jaw bones, both the upper and the lower jaw. Also, growth abnormalities between the upper and lower jaws, people who have resulting in malocclusions or the way their teeth fit together that are not amenable to routine orthodontic care that may require surgical moving of one jaw or both jaws. We're responsible for the temporomandibular joint, which is the jaw joint.
Yep.
And so all the things that occur in and around that joint is also in the spectrum of things we do. And then we participate in our cleft and craniofacial programs here at Boston Children's Hospital. I personally care for patients with cleft lip and palate and provide care to those patients, usually when they're a little older. So not as infants, but when they're sort of 10 years of age and older. There's a variety of surgical procedures that they need during that time frame.
Yeah, we had a podcast, actually, great discussion with Dr. Carolyn Rogers, who is involved in caring for these patients. And so I imagine you work very closely with her.
Closely, yeah.
So you do a lot at the program.
Yes.
It's really much more comprehensive than maybe I might have realized. When I think about all those, complex situations, it's great to know that we have a place where we can go. I mean, I've taken my son to see your team as well to evaluate him for oral surgery, so it's really great.
Thanks for coming.
So let's talk a little bit about research.
Yes.
You mentioned something about the research that had been going on related to pain management. I always love to ask our experts about, what has happened or what is going on in the future related to research in this area.
So Specific to wisdom teeth, I mentioned one study which was regard to postoperative pain management, which was, I think, a very important study because it changed our practice. We we're trying to be very cognizant of exposing narcotic naive teenagers to narcotics, and so we were able, based on the results of our study, to eliminate prescribing postoperative narcotics in our patient population. Another study that our team did was looking at our patient population with unique challenges, including our young adults on the autism spectrum. Parents of these patients are often concerned that they may not be able to share with them in the postoperative period their needs, and they're often concerned that they're going to have a really rough postoperative course. Those patients did better than those that didn't have those needs.
Oh, wow.
Yeah.
Well, that's fascinating.
Yeah.
And that's a great advantage.
It was good, and I think we can quote that paper, and it helps put parents at rest, make them feel better, and put them at rest that the procedure is actually well tolerated.
That's great. Yeah, I mean, for every parent, you're always worried about, is your child going to be in pain or,
Right.
Have any difficulty recovering from any surgery. And so that's got to be very reassuring.
We've used this model also to look at pain prescribing practices for patients having jaw surgery in our program, and other operations. So again, to try and really eliminate or mitigate the need for postoperative narcotics. So that's some of the other process improvement in our research that we've done in our program.
That's amazing. Well, so, I think we've talked a lot about wisdom teeth, when to have them removed, why, what that process looks like to hopefully alleviate some of our listeners' fears. Is there anything we haven't talked about yet, Dr. Padwa, that you want to make sure we share?
We did miss one thing, which is to discuss the risks involved in taking out your wisdom teeth.
It's a good point.
So the risks, there are a variety. I would say the standard risks are those of any procedure. So things like the possibilities of postoperative pain, bleeding, infection, swelling. And then there are the risks that we always tell patients that as surgeons we could potentially hurt or damage other structures that live in the area that we're working. So that would mean other teeth, bone, and gums. Obviously, we're very careful not to do that. The final thing patients need to be aware of is that there are two nerves which run close to the roots of the lower wisdom teeth. One nerve that supplies feeling to the lower lip and chin, and one nerve that supplies feeling to the side of the tongue. And there's always a chance of when taking out the lower wisdom teeth that one or both nerves could be damaged, leaving patients with either temporary or permanent numbness to the lower lip and chin and or the side of the tongue. The good news is it's a relatively minimal risk. We usually say less than 1%. It's not common that happens, but patients should definitely be aware.
Yeah, so good thing just to know that is a possibility.
Yes, it's always a possibility.
And that's just a part of, the location of where you're operating. Yeah, makes sense. Well, as we wrap up, the one thing that we always love to end with is doctor's orders. And this is my favorite part of the show, where you essentially prescribe something that parents can do to help them raise healthy, happy kids. So, Dr. Padwa, what are your doctor's orders for us today?
If your dentist recommends that you see an oral and maxillofacial surgeon for a consult, come in and see us. Again, it's not an emergency. It's not urgent. Do it in a timely fashion, and we'll be able to tell you if and when the wisdom teeth should be removed. If you put it off too long and forget about it, your child may end up with a problem that they didn't need to have.
So important. That's what we want. Healthy, happy kids and healthy, happy teeth.
Yeah, exactly.
Thank you, Dr. Padwa, so much. This has been such a good and fun conversation. I've learned a lot, and now I'm coming to see you with my son very soon.
Okay, great. Happy to see him.
Thank you. Thank you so much, Dr. Bonnie Padwa, and our parent listener, Pam. If you'd like more information on oral and maxillofacial health or even general dentistry, check out not only our website, but also two of our other podcasts where we interviewed with Dr. Elaine Smith from General Dentistry and also Dr. Carolyn Rogers on cleft lip and palate. We hope that you find this episode and all of our other episodes helpful as you raise healthy and happy kids.